Okay, thank you everybody for joining us in person, and for our virtual attendees, welcome. My name is Mike Vellick. I'm co-chair of the RTi3 meeting, and I want to welcome everybody to our annual pre-conference webinar. So just a word about the meeting. It's held at the end of May, beginning of June here in Toronto. All the conference information has been posted online. If you follow this link, you can see our proffered program, and we have an exciting lineup of keynotes and other special sessions as well. So please visit, and I also encourage everybody to take advantage of the early bird registration rate, which is valid up until April 24th. So you have about a week there. If you're interested in obtaining continuing education credits for this webinar, you're going to get an email if you signed up following this webinar, and you have to complete a short survey and quiz, and then you'll get a certificate for your link. So just be aware of that. It's coming to your inbox. So today's speaker is Ms. Gillan, who's going to be speaking on the human side of artificial intelligence. Caitlin has been a radiation therapist here at Princess Margaret Hospital since 2008. She's also an assistant professor in the University of Toronto Department of Radiation Oncology. She's a fellow of the CAMRT and has also been a past member of the board of directors. And she's also been past co-chair of the RTi3 meeting as well. Her research interests include interprofessional education and practice, in particular, how they relate to the introduction of new technologies in radiation medicine. So she's going to be speaking on this very timely topic today. Caitlin?
So thank you to Mike, thank you to the University of Toronto and to the RTi3 conference for having me here today. So my objectives today are first just to equip you with some of the basic terms and concepts around artificial intelligence. It's a bit of a daunting topic for those who haven't waded into it yet. And then to use that newfound knowledge to situate the evolving role of the radiation therapist within the relevant regulatory, ethical, professional, and educational considerations for AI in our future practice. So firstly, the number of words and abstract concepts and sort of futuristic hype around AI really do make it a daunting sort of concept or topic to wade into. And even those of us who really do have an understanding of some of the related words and concepts just don't always fully appreciate how they all relate to each other. So I do want to say that I might not be able to provide a fully comprehensive overview of all that. I think I went through and sort of cherry-picked some of the terms and concepts and ideas and research that I thought might be interesting, just to give us an idea of the potential for AI. That said, there really is a clear place to start, and that's with an idea of the definition of artificial intelligence itself. So I think all of us in everyday society have a basic idea from, our virtual assistants like Google Home or Alexa, the idea of driverless cars, our Netflix recommendation tool that tells us what show to watch next. But what brings us all together is that artificial intelligence is the study of agents that receive presets from the environment and perform some sort of action. So basically, a computer system that gets some sort of signal or data input and enacts a form of rational response based on that. So there's a clear way to organize our thinking, and the way that I'm going to organize how I present some of these ideas over the next little while. And firstly, that a system needs some form of input, so the data that's fed into a system, it needs some method of crunching that data and manipulating it, and then it needs something, some sort of output or purpose for having used this system in the first place, a way to sort of spit out the data. So I'm going to start at the beginning here with the input to the system. And the input in many situations is big data. So that's sort of the first term I'm going to go over. Big data basically is the huge, massive amounts of data that are available to us that are basically beyond the realm of human capacity to deal with. So it requires a computer system to crunch the data in such a way as to reveal patterns and trends that can be of use to society. So there are 4 V's in big data, and really every day someone seems to come up with a new V, but I'm just going to stick with the 4 basic ones here. So volume, variety, velocity, and veracity. Volume is just the amount of data that's available in modern society. So one statistic that sort of brings that home is that by 2020, so next year, 300 times the amount of data will exist as existed in 2005. So over the space of 15 years, we're going to have developed 300 times as much data as existed before that. So then there's a number of varieties of data, or types of data that massive amount exists at. And that can be our social media data, our cell phone metadata, emails, work data, images, videos, monitoring devices, wearable devices. All that data contributes to what's available in big data. Then there's velocity, and that's just the ways in which modern computing systems are able to produce data, stream it, and then analyze it. And finally, veracity is a little bit of a different beast, but that's the degree to which we can trust the accuracy of the data that's out there. So those are a quick overview of the 4 V's of big data. That's quite a common term or concept you'll hear of. Another way of looking at the types of data that's probably quite relevant to us in healthcare is the idea of structured versus unstructured data. So structured data is really only about 20% of the data that exists in the world, and that's the data that's really easily organized in a database. So numbers, dates, strings of data, it's easy to store, it doesn't take up a lot of room, but again, it's only about 20% of the data that exists. Unstructured data is everything else, 80% of the world's data, and that is images, videos, emails, text, all that stuff that just can't be stored as easily, and it's so much more unwieldy to deal with. And finally, just again, a slightly different creature is the idea of the Internet of Things, or IoT, which you'll start to hear about. And that's the connected devices that are embedded in our everyday objects. So things like the black box on an airplane, the things that make your home a smart home, so your Nest thermostat, the things that you wear on yourself to monitor your vitals or your running stats or anything like that. So that's the Internet of Things. When we apply it to healthcare data, it becomes the Internet of Medical Things, or the IOMT. So that's a quick overview of the types of data that can be fed into a system. The next is the ways in which we can crunch that data or deal with that data. Some of them are pretty straightforward. If you think of your smart home, it sort of collects data and then spits that out perhaps in a report for you, or monitors if something reaches a threshold or not. But I think what I'm going to focus on today in terms of the manipulation of data is mostly the idea of machine learning. So before I wanted to go into that, this is sort of where some of those scary sort of terms start to come up. And there's different ways of looking at them. Some people use a lot of these terms fairly interchangeably. Some people see them sort of as nesting categories like that. And this is one that I think it's important to articulate, that machine learning and artificial intelligence are not interchangeable as terms, though you'll find that a lot of places in this talk I sort of refer to them fairly interchangeably. But really, artificial intelligence is a term that was coined in the 1950s. So it looked very different then than it does now. But artificial intelligence is exerting a rational response based on input data. Machine learning came around about 30 years later, and what makes that different is that it's the idea that the system can improve its performance as new data is fed in. So it learns as it crunches new data. Then deep learning differs from that in the complexity of the system as it learns. So an example of deep learning, and for those of you who are writing their MDCB quiz after this, the idea of artificial neural networks will come up on that. And it's an example of deep learning. And it's sort of analogous to the neural networks of the brain in that it's complex layers of neurons or networks that as data is fed into the system, it can, if it meets a threshold, it can enact the next layer. So it's all these complex layers of systems that make deep learning different than machine learning. And you can see there was basically about 30 years between each of these developments, but I have a feeling that the next big development is not going to wait till 2040 to come along. So when you feed data into the system, there's a process by which the data or the system needs to be trained. So you can take this, in this case, unstructured big data, feed it into a system. The system synthesizes it in some way, but then a human is sort of needed to modify and provide feedback to tweak the system so that the output is what the human wants to see to be able to use it to be applied. But there's really 2 big categories or 2 big ways to train the system. One involves humans, and one can be done independently of any human intervention. I'm going to go over those briefly now. So they're the idea of supervised learning and unsupervised learning. So with supervised learning, there's actually two things that need to be fed into the system. The data that's being input, and then for each element of data that's input into the system, it needs to be labeled manually by a human. So basically, you're telling it what the desired output of the system is. So in this case, we've got 4 images, 2 of which are ducks and 2 of which are not ducks. And for some reason, we were interested in a system that could actually identify ducks from not ducks. And so the output, the desired output that we feed into the system is a label of this is a duck and this is not a duck. So you're basically feeding that all into the system, and the system's going to look at that and say, all right, so the things that were labeled a duck were these big blobs that had these little orange sticks coming out of the bottom with other little orange sticks. And there was another little blob up there and another little stick that came out of it. So the system doesn't know what a duck is, doesn't know that that's a beak and that those are 2 little legs, but it starts to learn to pick up on the things that were identified as a duck have certain characteristics, and the things that were not a duck do not have those characteristics. And so eventually we can feed a new picture into the trained system that is not labeled and use it as a predictive model that now the system can look at that and say, oh, okay, I see all the same characteristics as the duck. So I can now predict as a learning system that this is a duck. So that's supervised learning, where it needs to be manually tagged in order to train the system. In unsupervised learning, we don't provide any information at all. We just throw all this data at the system, and it needs to deal with that in some way. So what it does at that point, it doesn't know what's a duck or what's not a duck, but it clusters it in some sort of strategic way based on characteristics that it picks up. So here it picked up on the fact that 3 of those had very similar characteristics, and it clusters them in a certain way. But we didn't actually need to tell the system anything at all for it to be able to do that. But we do need to do a little work at the end of that to actually deal with those clusters in a way that makes sense for our purposes. The thing that comes into play here in both supervised and unsupervised learning is that we're dealing with a bit of a black box in the middle there. We actually don't know what characteristics the system is using to define. We can make some assumptions that it sees a little beak and it sees little legs, but we actually don't know what sort of logic or characteristics or variables the system is using to classify things in certain ways. So that's a bit about the sort of system in the middle, especially for machine learning that deals with the input and provides an output. But now there's sort of the forms that the output can take. So I talked about machine learning, and this is sort of a quick little graphic, and it's a bit misleading because I don't think these are all necessarily mutually exclusive. The example I just gave was one of image recognition, which was a form of machine learning in this case. So some of these sort of map onto each other, but some of the different examples of the output of a system might be speech to text or text to speech, natural language processing, which could take something like an email or even a dictated hospital EMR record and actually pick out certain data, certain words, translate things, classify certain documents in certain ways. Then there's the idea of robotics, there's optimizing systems, there's a number of different elements that could fall under artificial intelligence. And some of that is purely automation, so robotics could be purely automation, which some people don't include under the heading of artificial intelligence, but there's sort of an idea of the types of things that exist. So now I'm going to go over some what I think are cool examples in healthcare. So I just want to be clear that these are not necessarily the biggest and brightest ideas in healthcare, but I wanted to sort of find a good cross-section of the type of stuff that's going on out there, just to give us an idea of what the potential would be within healthcare. As we're going through some of the examples, watch for some of the commonalities between a couple of these. So one being the incredible amounts of data that need to be fed into a system, and also the incredible amounts of data that get spit out of a system in AI. Watch out for some of the monitoring systems that are out there where we sort of offload the task of monitoring to a machine. And there's some other ones about professions that I'm going to get into in one moment here. So another thing to watch out for is that there's a lot of hype out there about the impact of some of these examples on the workforce. Some of these are fairly neutral, just saying things are going to change. The future of our work is going to change. Some of these are a little bit more alarmist, saying our jobs are threatened, and that also goes for healthcare. Some of them are a little bit more restrained, saying, okay, at least for now we're okay, but eventually our jobs might be affected. And some of them are actually a little more positive, saying, wow, this is actually going to be really cool for people in the workforce moving forward. So while I'm going to get into a lot of the professional implications really heavily a little while later, as we go through some of these examples, think of the human that was previously doing that job and what that might look like for that person. So the first example, many of you may have seen this example. It's a commonly referenced one. This is in dermatology. So this is the idea that they have in this report, they developed an app where you could take your cell phone and you could take a picture of that mole that you've been worried about for a little while and just haven't had a chance to have it looked at, or maybe you're sitting somewhere on a 6-month waiting list to get to see the dermatologist. But you can take a picture of that mole and basically be told whether your concerns are valid, whether you actually need to go and see that dermatologist. So this is an image here of a neural network. So 130,000 images, this is all unstructured image data, 130,000 images were fed into a system. Each of these images was manually tagged, so that is supervised learning, as being either malignant or benign, and according to one of a number of different skin diseases. So then, when you take your picture of your lesion and you feed it into the system, it could compare that picture against all the pictures it has in its system and actually tell you whether it's malignant or benign and whether you need something done about it. So this system in this report actually performs pretty much on par with, in this report, it was 21 expert dermatologists, and the system did as good a job as those dermatologists of discriminating malignant versus benign. And of course, with each image that's fed into the system, the algorithm improves and its ability to discern that improves. So this is work that is also being done, similar work is being done in radiology, in ophthalmology, and pathology right now. So this is a completely different example, but again using machine learning. So this is to predict the clinical outcome of children presenting to an emergency department. So in this study, they took 21,000 what they called nationally representative pediatric emergency room visits, and they crunched some of the data that was available to them about those visits. So they only used data that would have been available at the time of presentation to the ER. So the age of the child, vital signs, their presenting concern, how they arrived at the hospital. It took all of those and it fed them into a series of algorithms to try and predict whether that child would have been best served by being triaged as to requiring urgent care, or they could have been triaged a little lower on that scale. So if you look at it here, this is comparing specificity and sensitivity. So the more solid, lower, less stepped curve there is the reference model. So that is the conventional means of triaging someone in an emergency department. So a nurse, clinical judgment, maybe a checklist and a clinical guideline as to triage them. All these others are various machine learning algorithms. And so all of these performed better, maybe only marginally better, but all of them performed better than the conventional technique in discriminating between children who needed to be triaged as urgently, like as higher priority versus those who could have been done with being triaged as lower priority. So the intention of this model is to avoid the under-triaging of critically ill children. This is an example of an optimization model in a scheduling system. So this is a chemotherapy department looking at optimizing the scheduling of both its patients and its nurses. So it operates sort of similarly to our planning system, where you feed a bunch of objectives into the system and then it crunches a bunch of possibilities and spits out what it thinks is the best option for you. So in this case, it might feed in priorities like minimizing patient wait time, minimizing nurse overtime, prioritizing that the same nurse work with the same patient day to day, that the more experienced nurses work with the more complex cases. So it feeds all those priorities into a system and it presents what it thinks is the best model. And it's a learning model because if one day it puts out a schedule and the nurses all worked an hour of overtime, it actually learns from that and incorporates it into the algorithm moving forward. So it offloads that scheduling from a human scheduler to a system. This is an example of IOMT, or the Internet of Medical Things. So it's basically a monitoring system. So in this example, it's dealing with patients with diabetes who would normally, because of the complexity of their disease, be managed as inpatients, but can now be allowed to be at home because of a series of devices and wearable devices and other connectivity within their home to manage things like their insulin levels, their lower extremity perfusion levels, vital signs. If all of this can be managed in the home so that a responsible clinician is just alerted if something's out of a threshold or if someone's in trouble, then it can allow a huge degree of patient autonomy, as well as saving very precious resources to allow a patient to be managed at home rather than in an inpatient setting. So this has also been implied in areas like cardiac care, palliative care, even some forms of dementia. Can also build in things like teleconferencing systems and medication reminders to still allow that form of interaction between the patient and the caregiver. This is maybe a bit of a different example, and this sort of brings in some debate over the idea of, we could call it artificial empathy. So this is Pepper. Pepper, and I'm going to refer to Pepper as if she were a human. Pepper is a humanoid robot. She was developed in Japan. She has a series of sensors and cameras on her that can allow her to read facial expressions, emotions, tone of voice, body language, and all these things, and exert a very calculated response based on those sensory input that the equipment receives. She was initially built as sort of a virtual assistant tool, but she's increasingly being used in healthcare settings, from anywhere from a hospital greeter to actually sitting with unwell or elderly patients as a form of comfort at the bedside. So now let's get into some radiation therapy examples. Some of you are probably already thinking of examples that you've already seen or some cool places that it could be applied. These are just a couple of examples right now. So this is an example of auto-contouring, or the ability of a system to contour organs for planning. So I picked this example specifically because it talks about the idea of a Turing test, which is an interesting concept to apply. So this was a comparison of human-generated contours versus machine-generated contours. And what a Turing test is the idea that if you can't discriminate between whether something was done by a human or done by a machine, then the machine's probably doing a fairly equivalent job to a human. That's sort of the basic idea of the Turing test. So what they did was they took a bunch of contours, some done by humans, some done by machines. They blinded a participant to where the origin of the contours was, and it asked that person to guess whether it was done by a human or a machine. So just to interpret this, the blue here is where the participant guessed correctly as to who did the contours, and the red is where they guessed incorrectly. So in all of the examples except the heart in the esophagus, it was about 50-50. They were just as likely to guess correctly as they were to guess incorrectly. The pie charts are just the overall guesses, incorrect versus correct, and then the bars below them are whether they were incorrect or correct when the result was that it was done by a human, or when the result was that it was done by a machine. So that's sort of interesting to know, other than the fact that I could probably contour a lung with no expertise whatsoever. So I don't know how I feel about the lung version. However, the extra part to that is the time savings on it. So an incredible amount of time savings if a clinician just had to go in there and edit machine-generated contours versus having to do them from scratch. So the physics resident who sent me this study actually also pointed me to a website you can see at the bottom there, where you can actually participate in the Turing test. So you can log in, go in, and you're blinded. You see a bunch of contours and you guess whether they were done by a machine or by a human. So this is another really cool example. This is a study currently underway by that physics resident who sent me the first example, Lee Conroy, and her colleagues. She's being supervised by Chris McIntosh and Tom Purdy. This is looking at a auto-planning algorithm for prostate VMAT. And the interesting about this is a number of us have seen auto-planning, but this is machine learning auto-planning. So it actually learns with each plan it's fed and each decision it makes. So the first round was the idea that fed in 74 plans. So I actually think that wasn't very many. It took 74 human-generated plans, fed them into this algorithm, and then the algorithm was trained. After that, it took 17 new data sets, fed them into the system, and had them planned for prostate VMAT. Then 2 radiation oncologists and a physicist were blinded and told, here's some plans that were generated by a machine, and then it also took the planner-generated versions of each of those 17 plans and showed them to the clinicians. And they had to decide, of the 2, planner versus machine, which one would they have preferred to use for treatment. So here are the results of that. And the vast majority chose the auto-generated plan over the human-generated plan. So on the right there, it suggests that on a per-patient decision, if you were to get those 3 clinicians together and have them together agree on which plan they would want to use, in 12 of 17 cases, they would have chosen the auto-generated plan over the human-generated plan. In this case, it was a retrospective study, so the human-generated plan had already been used for treatment. Now we're moving into round 2. We're taking a brand new CT SIM data set. Planners planning it on one side, machines planning it on another side. It goes to a group of clinicians, and they're going to choose which one is used for treatment. So that's going to be quite interesting. And that's underway right now. The other interesting thing is that algorithm is not actually specific to prostate. It was only used for prostate here because they fed in prostate plans as a training data set, but it can be used for other anatomical areas. And this technology, this algorithm, has now already been licensed to RayStation and will be in clinical use in the near future. So when I was first asked to give this talk, I sort of thought it would be interesting to do a bit of a day in the life exercise. So beyond these formal examples, some of the places where I see AI could come into play. And I thought that might be a little bit much, but I do still want to take some time to give some cool examples of where I could see AI coming in the future. So 2 caveats to that. First, some of this is probably already possible. It's just financially prohibitive, or we just haven't been bothered to actually put this into place yet. And the other is that we probably have to deal with some privacy considerations and some of our sort of surveillance issues before we use data in such a way. But a couple of the examples. So first, we've already seen a scheduling system in one of my examples here. So imagine being able to save on some of our precious patient interaction time and not have to use that to deal with patient scheduling concerns. So imagine if 90% of our patient scheduling considerations could be dealt with a rule-based patient self-serve model where we feed a bunch of rules in and the patients can deal with most of their requests for appointment changes, and we just need to deal with the ones that the machine can't manage. Imagine if our QC could be done by a machine. As nuclear energy workers, we probably still need to be present for it, and it probably still needs to be done. But if we could press a button and let it do itself while we could be busy with other things, that would be a huge amount of time savings. For some more clinical examples, imagine a prostate patient who could go into a little vestibule off the waiting room and actually self-scan their bladder to decide whether they needed to drink more or wait more time before treatment. Imagine a intercom system that immediately translated for us. So now we wouldn't have to refuse patients from ABC based on English proficiency, and we could actually talk into the intercom system and it would automatically translate to the patient in the room. That's a cool one. What about, this is one that would be dear to me, what about a CNS patient, that's the population that I treat, that at the beginning of their treatment, we often tell them at some point in a couple of weeks, you're probably going to lose your hair. Not all of it, but some of it, I can't tell you exactly when. Imagine a treatment planning system that could actually flag us at the exact moment that that dose had been delivered, that reached a threshold on their scalp. So at the end of treatment that day, 3 or 4 weeks into treatment, we could pull them aside and actually show them an image and say, you know what, it's reached that threshold, probably in the next couple of days you're going to start to lose your hair. So those are just some examples. Planning, our threshold, based on all these advances in planning, our threshold for replanning, for adaptive replanning, has gone way down because it's less resource and time intensive. So I need to be much more plan literate at the treatment unit to be able to make these decisions as to whether we need a replan. Planners are also much more focused on complex, unique plans that the system just isn't able to manage. They're interacting much more with the oncologist and the physicist and the therapist at the treatment unit about adaptive planning. When they're not doing any of that, they're probably working on library plans to help train the system for techniques and protocols that the machine's never seen before. So it needs some quality data to feed into it. So those are just some examples of what I think could be coming in the future. So just to sort of summarize and distill this all down to what a machine might be good at versus a human and some of the weaknesses. So machines are better at those rule-based tasks. They capitalize on that incredible computational power. Humans are probably better at that context-specific, requiring ethics and value judgments, physical tasks, common sense, which I'll go into in a minute. However, the machine does require huge amounts of data to be able to perform in an accurate and reliable way. That might not be that different from humans relying on experience to develop expertise. You'll also notice a big one is that bias does not just fall under humans. Machines are not these objective things that are immune to bias, and I'm going to go into that in a few minutes. But one example first that I'm going to provide, just about the idea of common sense. Some of you might have seen this. It's a meme that's sort of going around. But I just want to put across the idea that sometimes when AI gets it wrong, it gets it very wrong. So we can all tell which ones in here are animals and which ones are breakfast foods. But an image recognition software actually couldn't differentiate between the two. And if you really think about it, you can probably see why. The certain characteristics that's picked out of this are very similar between the two. So just to keep in mind, and I think it's an important thing that we keep in mind as we're working with AI, is that sometimes this sort of common sense that people have, machines just don't have. So on that note, it's important to consider some of the other challenges that we might be faced as we move forward with AI. And I call this the we really thought this through section. So does anyone know what this stands for?
Garbage in, garbage out.
Thank you. Garbage in, garbage out. So in the sense of AI and data, it means that if we feed poor quality data into the system, we're going to get a poor quality output. So really an algorithm is only as good as the data we fit into it and the model that is built around it that is employed. So some areas we need to think about that. Whose data are we feeding into the system? So it's commonly known that Caucasians are more likely to sign up for clinical trials than our other populations. So if our algorithms and our models are only built on data that comes from a certain set of genetics, socioeconomic status, physical makeup, what kind of human equity issues are we bringing in to the appropriateness of these resultant models for other populations? What about the context in which these models were created? So if we're looking at CT data sets that were created using only GE equipment, and then now we're trying to apply it in a Philips environment, what are some of the nuances around voxels, Hounsfield units, contrast that might make it actually that it doesn't apply as well as that context? What about as protocols and clinical guidelines change and a model or an algorithm might become outdated to its current use, and what might that do to a model? As well as the model, any bias is held by the people who build the model, the people, the vendor, the funding that goes into building that model could be perpetuated in the model, perhaps even more dangerously, because that model could then go and be applied much more broadly than that single person or group of people, and we might not be as reflective of the potential for bias in a machine as we are in a human. So that concept of GIGO, or garbage in, garbage out, is an important one. Then we come into the ethics, and there's probably no better way to consider the ethics or moral judgments that come into AI than with the idea of driverless cars. So if you look at situations like this, where it's sort of split-second decisions of impending accidents, where there's no easy decision in any of these, someone's going to get hurt or something's going to happen. So how do we deal with this? And this is a current debate that a lot of ethicists are having in sort of making up some of these rules for driverless cars. Which outcome here is better? Who gets to decide this? If you're driving that car, we're somehow a little bit more forgiving of a human who needs to make a split-second decision than we are of a bunch of people sitting around in a boardroom trying to decide how they're going to program all the driverless cars in the world. Then they're sitting around and they have more time to think about some of these things. Also, does it depend? If I'm the one driving that car and I have a loved one in the back seat, there might only be 2 of us in the car, but I'm going to hold our 2 lives as more valuable than the 5 people in the intersection. But again, someone sitting in around a boardroom might not feel that way. Also, the depend of, are those 5 people in the intersection, are they supposed to be there or are they jaywalking? Does that depend then? And how can that be, that value-laden and context-driven considerations, how can those be built into a system? So you can pretty easily make the analogy into healthcare and some of the considerations we need to deal with there. Then there's the idea of the black box. I've already talked about that. The idea of the black box is not just that a vendor says, I don't want anyone to know what's happening in here. I don't want to tell you what my secret sauce is. It's the idea that in many forms of AI, it's actually not possible to trace the logic of a decision back to how an outcome was derived. So that's an important concept. So wouldn't it be important for you to know if an output or a decision of a machine, how confident the machine was in that? Was there another completely different outcome that was only marginally discarded for some reason? What kinds of variables were included in the model? What kind of variables or factors were not included in the model? So these are all things that I would want to know if I was judging the appropriateness of a model, but in many situations, that's not possible. So this is a comic. I would say that this is probably a sort of financial situation, that this poor woman has been denied a loan or a mortgage. So imagine being that woman where she can't ask why she was denied. She can't challenge that decision in any way. She can't know the reason so that she can go home and change her behaviors in some way so that she could come back the next year and apply and be successful. So apply that to healthcare. If you're a patient and you don't know why certain decisions are being made or certain outcomes or why you've been referred in one direction versus another. Now consider being a healthcare provider in that situation and the idea of accountability. If something is spitting out that you need to triage a patient in a certain way and that goes against your clinical judgment, who gets accountable for a decision like that? Is it the developer of that algorithm or that model? Is it the employer that purchased it, plunked it in your ER, and told you that you needed to use it moving forward? So these are a lot of considerations that we haven't really prepared ourselves for. It's a bit of a tongue-in-cheek comic, but it is important these days because as of right now, a machine is not a legal entity. So it can't be held to blame for a decision. It would be the human in some respect that would be. So some people are starting to think about these considerations. These tend to be broad public policy voices, not governments or anything, but advocacy groups that are starting to advocate not solely in healthcare, but more broadly. So this is an example of a group in Europe. This is the Universal Guidelines for Artificial Intelligence, and I've selected some of the things that it believes people have a right to. So the right to transparency, so that we know where these decisions came from. That's the explainability element. The right to human determination, which is a statement that says, in the end, all decisions must be made by a human. So the machine can spit something out, but it must be a human who enacts that decision in some way. And the one that I included that I think is pretty interesting is this termination obligation. So that's sort of the machines take over the world clause, in that if ever a machine gets to the point where it is taking actions without any form of human intervention or any human intention behind it, then humans have a requirement to shut it down. So I think that that's pretty interesting. Another one, this came around a few months later from Montreal. It's the Montreal Declaration for Responsible AI. It sort of has a similar purpose, but maybe takes a bit more of a highbrow, human equity, no negative impact on the fabric of society types of statements in here, but very similar. And so we're all starting to talk the talk, and now it's governments looking to this to say, how do we actually enact any of this? And it's starting to happen. So one example is the EU recently enacted a General Data Protection Act, one of which stipulations of which is that all future developed AI or machine learning must be explainable. And there are a number of research and development grants that are now putting clauses in saying we will not fund you unless your resultant model is explainable. So we're starting to have the right conversations and take the right actions. So what does this all mean for us? And what are the implications on us, both as healthcare professionals and as radiation therapists? So first of all, and I'll thank Tom Purdy through Mike Velick for pointing this out to me. But this is a website hosted by the BBC that actually tells us how likely we are to lose our jobs to automation. So if I put in medical radiographer, that's the British equivalent of MRT, so it includes diagnostic in there. But if I put that in, what percentage do you think we'll see? Higher than 50 or lower than 50? Higher. I'm hearing a couple of hires in my live audience here. So I was actually a bit surprised that we are only 27% likely to be automated. Take that for what it's worth. The system here says, or the website says, that if part of our job requires negotiation, helping and assisting others, coming up with original ideas, then we're probably pretty safe from automation. I would argue that we do all of those things, but I would also argue that many people as professionals or even who hold jobs think that they do all of those things. So what I want you to take from this is just that isn't it pretty interesting that someone felt that the need for such a website existed? And it's sort of a fun game to go in there and play with different professions. Put in radiation oncologist or medical physicist and see what you get. So this is an interesting and very relevant analogy. This was first expressed by Dr. Brian Hodges, who is the Vice President of Education here at the University Health Network in Toronto. And he first published this in an editorial in 2017. This is the idea or the analogy of Dorothy Vaughan. And so Dorothy Vaughan was played by Octavia Spencer in the movie Hidden Figures a couple of years ago. And she was, in the 1960s, in the race to the moon, she was one of a number of African-American female scientists who worked for NASA basically as human computers, just crunching the numbers, dealing with complex calculations. And one day she saw, this is actually a picture of her, she saw them wheel one of these into the department. So this is a giant IBM computer. And while everybody was sort of whispering to themselves about what this could mean, she took the initiative to read the operator's manual to this giant machine. And she then saw the writing on the wall and said, you know what, I think we're in trouble, we human computers. And so she rallied her colleagues. And over the next little while, she facilitated that they all attend night school. So when, sure enough, the IBMs were put into place as the new mechanism to do all these calculations, all of these women were retrained as computer programmers. So they took their existent skills and their aptitude for numbers, and they redirected that in a way that would be beneficial to them in a new way of practicing. And so Dr. Hodges' analogy was that maybe healthcare professions aren't thinking enough like Dorothy Vaughan. So he said, yet sadly, I see our professional organizations concerned with clinging to their current scopes of practice, clinging to their professional turf, whereas what they should really be doing is thinking about what we will be doing in an age of thinking machines. I think it will serve us all to spend less time declaring how complex and irreplaceable we are as health professions and more time adapting for a radically different future. And so what could that future look like? One way of looking at that is to think of the idea of the missing middle. So if we think of that there are certain things that humans are better at and certain things that machines are just better at by nature, and you can see some of the examples up there, what about those places where the two can converge to actually be mutually beneficial to each other? So areas where humans actually can help machines, we can feed high quality data into the machine, we can enact and interpret the results of what the machine spits out. What about places where the machines can actually use their computational power to give us knowledge that we just wouldn't be able to have without them? So that's the idea of the missing middle, and it came from probably one of the best books I've read on AI, and I've read a number of them in the last few years, called Human Plus Machine. And this was just put out by the Harvard Business Review a couple of years ago, and so it's an excellent read. Most of the examples in there are not about healthcare, but it's pretty easy to see where they relate. So there are a number of calls to action that are starting to emerge. Some of the professions are starting to recognize where they need to be a little bit more like Dorothy Vaughan in there. And a lot of the form that that's taking is white papers or position statements. So professional groups that are enacting task forces to sort of put out into the world where they think they need to situate themselves with relation to AI. So here's an example in pharmacy, another example in radiology, and recently there was an example in radiation oncology. So some of the commonalities between all of these are the importance of engagement, having a seat at the table to be aware of some of these conversations, to add their voice to some of these conversations, some of the education that is necessary, both for their members and for their patients about what AI could mean, what it should mean, research initiatives to make sure that when AI is introduced, it's introduced in an evidence-based and responsible way in the best interest of the patient. And finally, the advocacy along those same lines, that we're actually, professional groups are articulating to other stakeholders and to the public of where they see themselves within AI and how they're going to ensure that it's enacted in a responsible way. So within our context as radiation therapists, I haven't seen any formal white papers or anything like that yet. But there are some actions that are starting to happen. So a couple of years ago, the CMRT asked me and my colleague Brian Leszewski, who was a therapist at Odette at the time, to write a point-counterpoint article. And this was based on the fact that the CEO, François Criard, had been at a conference recently before that where there had been a statement that suggested that MRTs were being dumbed down by technology and our responsibilities were much less, and we were actually risking being obsolete as a profession because of that. So that was a really interesting exercise that we were hoping was going to get people talking. In a couple of weeks, the CMRT is holding a Game Changers in Radiation and Medical Radiation Technology Summit in Ottawa. And so this is bringing together MRTs, other professions, other stakeholders, industry to start to have some of these conversations. And if I remember correctly, their keynote is actually the author of the radiologist's white paper that I showed you a moment ago. So what's next? What's coming and where do we need to position ourselves in that? So the first thing I would argue is that we, in some respects, need to get our head out of the sand. So some of these places where we're in denial about AI, or we're panicking about our jobs, or we're running for the hills, or we're denying that AI is actually going to be coming, we need to change our thinking in that way a little bit, because it's not really doing any of us any services right now. So if you were a radiologist or a pathologist and you looked at that, you'd probably be pretty nervous. It's basically fundamentally saying that their jobs are going to change, that radiologists and pathologists, their professions are going to merge into a whole new beast as an information specialist. I can actually see how that would happen. Offload all the pattern recognition of their jobs to a machine and instead focus on interpreting and enacting what the machine spits out in the best interest of the patient. But if you're a radiologist, or a pathologist who doesn't run for the hills, doesn't take early retirement when they see something like this, doesn't say that's never going to happen, I don't want to deal with that, you're probably going to be the most well-positioned to be successful when this kind of change does happen. So in our own world, I don't know if anyone remembers this article coming out about 5 years ago. So Mike Sharp was a physicist with us, and he engaged in a similar counterpoint article. And based on the personality that he was, as soon as that article was released, he sort of strutted around the planning area for a couple of days because he wanted to be part of the debate that came from this article. Nowhere into this article did it say there will be no more planners in the next 10 years. Instead, it was arguing things like planners are going to be doing completely different things. They're going to have a different weighting to their responsibilities in their day. They're going to use their incredible expertise in a different way, not in the ways that they're using that now. And I would argue that in the 5 years since this was published, we've already changed our practice in some significant ways. So all this to say that really we need to be careful not to try to stay the same, because we're increasingly going to be that square peg that's trying to jam ourselves into an increasingly round model of practice. And so if we keep trying to do this, then someone else is just going to slip in and fit better into that practice model as we move forward. So avoid trying to become that, or trying to stay the square peg fitting into a changing model of practice. So what does that mean? It means a lot of the same things as the white papers that have already been published are arguing. I would advise you all to take a read of them. Even though those aren't our professions, they have a lot of important points that I think we would be, it would do us a good service to read and to think about. One thing within that we need to be careful about is not to try to be something that we're not. So wherever we see our practice shifting, it needs to make sense to our values and our ethics and our interest in a profession, which is really where technology and the patient come together. So that high-tech, high-touch space. We're not going to start offering legal advice to our patients. We're not going to start driving them to and from appointments. That's just so far out of our scope of practice that it doesn't make any sense. But where are these places where our profession can shift in those little ways to actually capitalize on who we are already as professionals to fit into our space a little bit better? So in the Dorothy Vaughan example, these were people who were good at numbers. They were already scientists. So they just shifted that to something that they saw as being relevant to the future. So let's not try and be something that we're not, but shift in ways that make sense to where we're going. So all this to say that we need to start asking ourselves some questions and being honest with ourselves. What aspects of our current roles are replaceable? Not just because they're tasks that we want to offload because we don't like doing them, like scheduling considerations, but what really does make more sense for a machine to be doing rather than us. Where are we best positioned as frontline therapists, educators, researchers, managers to advocate against transitioning to a machine? Some vendor might think they could develop something that would make sense to offload one of our tasks, but we know best what can be offloaded and what really shouldn't be. And what aspects of our current work can machines help us in what we do? And what aspects of our current work can we complement what machines can do for us? Those are the two that are around the sort of missing middle concept. And finally, this is a bit of a tough one, but we need to keep asking ourselves, are we prioritizing the quality of care and the benefit to our patients over the future viability of our profession? Because that's really what we should be doing. We aren't here to say, I want to still have a job in 10 years. We're here to say, what should the practice of radiation medicine look like that is in the best interest of our patients, which is why we all got into these jobs in the first place. So that's the end. Before I hand it back to Mike, and I think some questions from our live audience at least, I've been asked to be the guest editor for a special edition of JMRS, the Journal of Medical Imaging and Radiation Science, and that's the submissions are due May 1st, but I'm going to come out, and I hope Lisa and Carly aren't listening, to say there might be a little bit of flexibility on that. If there's any work that you have underway or any thoughts you have around AI and what it means for our MRT professions, then we would love to have your submissions around the end of the month. And if you're not working on something that's related or it's not going to be done in time, then watch out for the issue to be published in the winter. That's it. Thank you very much. Are there any questions from our live audience? I don't think we have the capability to get it from our virtual audience, but I'm sure if there's some people in here with questions, that those will mirror some of the ones that exist in our virtual audience. Anybody?
Caitlin, are there any examples where AI has gotten it wrong and the stakes are so high? I know we hear of Tesla's driving into semi-tractor trailers.
Yeah.
Are there any examples in healthcare or other?
So I can't think of a great one in healthcare. There definitely are some, but none come front of mind to me. But so I showed you that quick one of the sort of blueberry muffin and the chihuahua. But one that's maybe a little bit more interesting shows the nuance of how we don't always know what variables or what factors are being considered by an algorithm. So an example was they were trying to train a system to discriminate between a wolf and a husky. So that's an interesting one because they actually look fairly similar, but they were surprised that they actually, once they fed it enough supervised or labeled data, so they fed it a whole bunch of pictures that said this one's a husky, this one's a wolf, and got to the point where it was getting it right all the time. So isn't that great? But then they fed it one picture, and I think I'm oversimplifying this example, but here it is. They fed it one picture where it got it wrong, and it was actually a dog, but it thought it was a wolf. And so they looked at it, and they finally realized that the reason it got that one wrong is because this dog was sitting on a snowbank. So it wasn't that the software was picking up on characteristics of the dog versus the wolf. It was actually picking up on the fact that every single wolf picture was in a snowy background. And all the husky pictures were just of a dog in someone's backyard. So the characteristics they were using were not actually characteristics that a human would use in any way to discern between a dog and a wolf, but it was using something completely different that was completely irrelevant. So you could probably apply that to healthcare in some ways, where you could see that there was some completely innocuous factor going on in the background that just happened to be fed into the system, and the system used that and got it right most of the time, but then sometimes it would get it wrong, and it would get it very wrong. And are we able to tease out those times when it gets it very wrong? Bew.
That's a quick presentation, and I agree very much that the garbage in, garbage out philosophy, to some extent, it actually applies to human as well.
Yeah.
And do you foresee that the good data will one day become assets? Actually, people are willing to pay that money for.
Yeah.
And for institutions, do you believe that they should start to look at how they collect data and make sure the integrity and the best data they can gather and store?
Absolutely. Absolutely. So one issue is bias in data, and they're going to have to deal with that. And so one way to fight the bias in data is to have bigger and bigger and bigger data sets, where as many factors as possible are considered, so that data doesn't come from one single institution with a single practice or a single set of patient characteristics, for example. But another thing along those lines that's probably interesting in the planning domain is that so many times planners can optimize a lot of planners are probably saying, sure, the machine can get it right because it can try 30,000 times until it gets the best plan it can. But a planner is limited by the realities of the world, which is that they've got the next plan to work on. So you have to stop at a certain point and you say, this plan is good enough. It's not, if I could sit there for 3 more days on this plan, I could probably make it a little bit better, but I need to stop now. But in the future, we might get to a point where we actually, because of the weight assigned to each piece of data that's put into the system, we can actually assign planners more time because the basics are going to be offloaded to a machine, that a planner can spend more time refining a plan until it's as good as they can get it. so that when that data is fed in to now be used as training data to a system, every time there's a new technique or a new dose protocol or something like that, new data is going to need to be fed into the system, and someone needs to create that data. So I think that the human planners will have much more role in being able to be given the latitude to make something as good as their expertise allows them without some of those external pressures to feed that quality data into the system. In terms of monetizing that and saying, like, we want to be known as the people who make the best data and can actually sell it to others, that's a conversation beyond my pay grade. But I think that there's a lot of interesting considerations that are going to come up with that in the future years. Absolutely. Else? Mike.
Has anybody dived into what patients think of AI versus clinicians?
Yeah, so Mike's asking about whether we've started to look at what patients feel about this. And I think that this is interesting. And so there's part on the empathy side and the idea of that robot sitting beside someone's bed and holding their hand. So that's pretty interesting. And in Brian Hodges' paper that he wrote, he actually tapped into something that's really interesting. And a lot of healthcare professionals are saying, we can't be entirely replaced because we can deal with empathy and machines just can't deal with empathy. But then he actually said, really? Is that the case? Are we actually that good at empathy? Because we're too busy to be empathic right now. So maybe a little machine sitting beside a patient's bed who's comatose, or who otherwise a nurse doesn't have time to sit by the bed for 4 hours. So is that better than a person when there's no time? So there's issues around that. There's also issues, that study that Dr. Conroy's doing about looking at automated versus human-generated plans. I actually think it would be really interesting on the qualitative side to interview the planners whose automated plans are chosen over the plans that they just spent 6 hours laboring over, the clinicians who are having to make that decision, and then what about the patients? How do they feel about having a plan that was generated by a machine versus a plan that was generated by an expert? And do they have the wherewithal to understand some of the issues around AI and what that entails? So I think that engaging the patient in some of these cases is going to be very interesting over the next years in many of those different domains. Yeah. But maybe some of this actually frees up some of our time to actually have time to be more empathic and to deal with our patient interactions in a more quality way.
Any other questions? Okay, thank
Great.
you very much.
Thanks everyone for coming.